Chemistry who first described this phenomenon, and he is the person who developed variety of tests, including one of the most important, that is cost effective method for screening for diabetes and monitoring its control in urine by using sodium carbonate and heat. So he was the person who devised the way to diagnose as well as to treat diabetes, and the monitoring at that time was with the help of urine glucose monitoring, and that was devised by this person, that is Professor Michael Somogyi. We also know the amylase. Previously we used to report it in terms of Somogyi units. This was also invented by this Professor Michael Somogyi. This is the seminal paper based upon which the Somogyi phenomenon was described, and we all are stuck with that word. Whenever there is morning hyperglycemia, everybody thinks of that it might be Somogyi phenomenon, and very of intensifying treatment, particularly insulin therapy in candidates where it needs to be intensified. So what they have done at that point of time, they have admitted 3 people, young people, who were on high doses of insulin and who were having fluctuating diabetes, and as per the roster of their clinic, they were considered most severe unmanageable diabetics, and they were not able to lead their daily routine life. So they were admitted on several occasions, and they have tried to find out what is happening to their sugars by measuring their urine sugar, because that was the standard of care in 1959 when this paper was published. So this is one of their patients were admitted on several occasions. Every time they calculate how much total glucose is available to the patient through protein, fat and carbohydrate per day, and they calculate urine sugar. From breakfast to lunch they collect entire specimen and what is the total urine sugar in that, from lunch to supper, from supper to breakfast, and that way they calculate what is the total amount of urine glucose and what is the total amount of glucose that is utilized. Most of these people, they were on very large doses of plain insulin, 30-30 or 25-25, 2 times a day only. So probably the low sugars and subsequent hyperglycemia which was occurring was more related to the physiology or the action profile of insulin rather than to hypoglycemia, than contributing to hyperglycemia through counter-regulatory hormone release. So this is the way they manage each patient there, and they formatted this kind of graphs, and they shown that the days where urine glucose are less, these smaller bars, they are followed by days where the urine glucose is very high. So from that they made an implication that low urine sugar is always followed by a high urine sugar. So this, that is hypoglycemia, is always followed by a hyperglycemic episode. And they concluded this, that this is a paradoxical effect of excess insulin. And the title of their paper was Exacerbation of Diabetes by Excess Insulin Action. So what they have termed, excess insulin results in hypoglycemia, that results in counter-regulatory hormone release, and that results in hyperglycemia. And this is based on this paper that the Somogyi phenomenon, which we now routinely use the word in our literature, in our practice, is based on this primitive urine testing, showing that low urine sugar is followed by high urine sugar. There was a big controversy related to that, and many of the people, they were not believing in Somogyi effect. So this is the first paper which was published in 1980, where 15 patients who had 17 episodes of asymptomatic untreated hypoglycemia between 11 p.m. and 3 a.m. their morning blood glucose was measured, and those who were having morning hyperglycemia, which was observed only in 6 of 15 patients, there they have tried to find out what happened to their various hormone levels during night, that is growth hormone, cortisol, glucagon, and at the same time what happened to their free insulin levels during night. And they clearly shown that as the insulin level goes down, the blood glucose level goes up. So they concluded that the morning hyperglycemia was not because of counter-regulatory hormone, but it was because of lack of insulin action. There was lot of trials which were going on to find out, or studies, they were trying to find out what happens to hypoglycemia in non-diabetic individuals, and Cryer has done a lot of work related to that, and he has clearly shown that if glucagon secretion is inhibited, then recovery from hypoglycemia is markedly impaired during adrenergic blockade and fails to occur in the absence of epinephrine. So adrenergic hormones and glucagon, these are the two things which are very much important in counter regulation of hypoglycemia, that is insulin induced hypoglycemia in non-diabetic individuals. Cortisol growth hormone role is not that critical, and this is not sufficient to increase blood sugar to the normal range. Don't think of hyperglycemia. What Somogi proposed, hypoglycemia, counter-regulatory hormone release, and then it results in morning hyperglycemia. Here the sugar will not even rise to the normal level, even with the secretion of counter-regulatory hormones. And this was again summarized very well in this review article in 1985 by Philip Ruskin, that under most circumstances, unless food is taken to relieve symptoms, nocturnal hypoglycemia does not lead to a rapid and marked increase in the blood glucose despite the release of counter-regulatory hormones. And fasting state, insulin treated patient, hypoglycemia can persist for hours, and most of the time it is because of lack of insulin action and not because of counter-regulatory hormone release. If hyperglycemia occurs, then it is because of lack of insulin action. With the advent of glucometers and blood sugar monitoring, this is the study which was conducted in USA in Washington University Diabetes Research and Training Center, where they have identified individuals who were having nocturnal hypoglycemia, and then they have compared their sugars at 7 o'clock, 11 o'clock, 4 p.m. and 9 p.m. day before and day after the nocturnal hypoglycemia, and they concluded that nocturnal hypoglycemia does not commonly result in morning or daytime hyperglycemia in patients with diabetes sampled while using their usual therapeutic regimes. This was hospitalized patients. In 1987 in USA this trial was done. This is the only trial which was published in NEJM, very well designed, very well conducted trial, where the patients were on subcutaneous insulin infusion continuously, and then they were given extra intravenous insulin to develop hypoglycemia. One group developed hypoglycemia, allowed to develop hypoglycemia, and second group hypoglycemia was corrected with the help of dextrose infusion. And they concluded that there is Somogi phenomenon, there is release of counter-regulatory hormones, and probably this should be thought of in people who are on intensive insulin therapy. So only one trial to support Somogi phenomenon, whereas all other, they have refuted this concept of counter-regulatory hormone contributing to morning hyperglycemia following nocturnal hypoglycemia. But still, we believe that Somogi phenomenon exists, and we are wary of intensifying insulin therapy whenever the patients they develop morning hyperglycemia or present with high fasting plasma glucose levels. We all know that now we have advanced from the plain insulins to the ultra long acting basal insulin analogs with rather flat profile and action profile of more than 30 hours, and we have also moved away from urine glucose monitoring now to the era of continuous glucose monitoring. So continuous glucose monitoring can very well give an idea whether Somogi phenomenon is there or not. And this is the first trial which was published from 262 patients with type 1 diabetes, retrospective analysis they have done. And if you see this graph, this is morning blood glucose which is written here, and the dark bar it presents that the people who were having nocturnal hypoglycemia. So the people who were having nocturnal hypoglycemia, the morning glucose was generally less than 5. In most of the individuals, up to 80% of individuals, it was less than 2. It was never beyond 8, 9 or 10 millimole per liter. So morning hyperglycemia does not exist with nocturnal. If there is nocturnal hypoglycemia, the fasting plasma glucose will be low. It will not be high. The another trial which was done by Professor Pratik Chaudhary and Simon Heller, where they have tried to compare fasting capillary glucose values with the overnight lowest sensor glucose throughout the night. And if the nocturnal hypoglycemia was there, then the fasting glucose was also on the lower side. If there is Somogyi phenomenon, then here the blood glucose, fasting capillary glucose should come here, but it was also low. So those patients who were having nocturnal hypoglycemia, most of them, their fasting glucose was less than 90, as compared to only 2 patients who were having fasting glucose more than 180 with episode of nocturnal hypoglycemia, again saying that nocturnal hypoglycemia does not result in morning hyperglycemia. This is not related to Somogyi phenomenon, but this is a trial where they have tried to find out patients who are on insulin degludec. We consider degludec ultra long acting basal insulin analog, and the chances of asymptomatic nocturnal hypoglycemia should be lowest with this insulin, because that is the best insulin which is available currently. And if you see here, and then they have tried to find out, can we predict asymptomatic nocturnal hypoglycemia? Again, they have shown that if the bedtime glucose is less than 90 and fasting is less than 70, there are 80% chances that your patient is having asymptomatic nocturnal hypoglycemia, and you need to reduce the dose of insulin degludec. Again, this is against the Somogyi hypothesis of Somogyi phenomenon, that nocturnal hypoglycemia results in morning hyperglycemia. And this is last very large database analysis of 2,600 patients with type 2 diabetes, retrospective analysis who were on stable treatment of insulin. Again, same way, less than 70 sugar between 12 midnight and 6 a.m. in the morning, and then their fasting sugars were compared, and they have clearly shown that if fasting glucose is less than 70 in the morning, 100% risk of nocturnal hypoglycemia, while fasting above 9.6, forget about nocturnal hypoglycemia. So morning hyperglycemia is not reflective of nocturnal hypoglycemia. Low fasting plasma glucose, it gives you a hint that there may be asymptomatic nocturnal hypoglycemia, and you may need to modify the insulin dose. So this is proof of concept, a very large meta-analysis clearly showing that Somogyi phenomenon does not exist in real clinical practice. These are few cases from my own clinic. One patient, overall nighttime sugar, if you see, it is low, but the fasting glucose is again normal on 2 consecutive days. This is type 1 diabetic patient. This is another patient. Here you will say that there is a hypoglycemia at midnight, and then there is sugar is rising in the morning. Is this Somogyi phenomenon? No, because the patient has taken snake here, a large snake, which resulted in high glucose, and then he has reduced his morning dose of insulin and took a large snake again because of fear of hypoglycemia. So the blood glucose has increased, and modifying the insulin dose, just reducing the basal insulin, everything has sufficed. So whenever there is morning hyperglycemia, Somogyi phenomenon is very rare. It is mostly either because of dawn phenomenon or because of under basalization or low intensification of basal insulin dose. CGMS will help you in deciding that. If it is not available, then you check blood glucose at bedtime, at 3 a.m. and morning glucose. Bedtime glucose will be normal in all 3 categories. 3 a.m. glucose, if it is low and morning glucose is high, this may be Somogyi phenomenon. If 3 a.m. glucose is high and morning glucose is also high, that means you need to increase the basal insulin dose. If 3 a.m. glucose is normal and fasting glucose is very high, then it is generally because of dawn phenomena. To conclude, I will quote this take-home message from a beautiful paper by Professor Pratik Chaudhary and Simon Heller. The title of paper is also same, The Somogyi Effect, Fact or Fiction. So they have clearly given 5 important take-home points. First, low fasting glucose, always think of